So you'll all be familiar with the diseases that you get in MEN1 and MEN2, so I'm not going to labour the point. So hyperparathyroidism, so overactive parathyroid glands, common to both conditions, and then MEN1 patients get pituitary tumours, they get pancreatic tumours, and then MEN2 patients get medullary thyroid cancer and pheochromocytomas. So those are the main diseases. So what's the problem with dealing with patients who've got MEN when they become pregnant? So what we're always trying to do is balance the risk and benefit between mum and baby of, if they've got a disease, do we treat that disease or do we stop treating that disease so that baby is fine? So there's always this risk benefit of whether we withdraw treatment and just watch a disease or keep treatment going. So that's the issue. But there are a number of other issues that we also have in pregnancy. So there are lots of physiological changes in mum. So lots of things change. So when we assess disease, it becomes slightly different during pregnancy. Then the other issue is a lot of the hormonal ranges that we have, so we're trying to get hormones in certain ranges, they all change in pregnancy as well. So that it's not a level playing field, it becomes more difficult to assess. So the other problem is, so there are lots of problems in dealing with this. So pregnancy is an evidence-free zone. So you know doctors like evidence-based medicine, so we do trials in thousands of patients and then we say this is the right thing to do. So the difficulty with pregnancy is you can't really do trials, so you're basically trying to work out what you think the safest thing to do is, but that may not come with much evidence, specifically in conditions where there aren't many patients with these conditions worldwide. So that's the other issue. So this is a slight joke. Have you heard of the British National Formulary? So that's where we get lists of medications and all the, we call it contraindications. So when you're not allowed to give a medication or when you're allowed to give a medication with caution. So let's imagine air was a medication you could give. In the BNF, if someone was pregnant, it would say air, caution in pregnancy. So essentially what I'm trying to say is everything is cautioned in the BNF. So that's the other problem we've got. If you look at, so if you had water, it would say caution in pregnancy. So obviously I'm making that up, but what I'm trying to say is it's difficult when, if you go and say, oh, I'm on that medication, oh, but it says caution in pregnancy. So then that becomes a problem as well. So there are lots of problems with this. So when somebody comes along and they're pregnant and they've got an MEN1, they'll be in one of three probable categories. One is they've had a disease and they've had it treated, and so they're cured of that particular disease, but they may be on medications to replace a hormone which has gone away. So that's the first group of patients we deal with. So the next group of patients are patients who have still got a disease. It may have been treated and it's better than it was before treatment, but there's still a bit of disease there. So those are patients where we've got to monitor that disease during pregnancy. And then there's a final group of patients where there's a disease process which may have only just been picked up during pregnancy, or it's quite aggressive and we're having to and the patient is pregnant. So we're having to balance treating that disease, which is a bit more aggressive, with the pregnancy as well. So there are different things that we have to do in pregnancy. If somebody is on a hormone, let's say, we have to monitor the levels, okay, or we have to monitor the disease. If they're on hormones, we have to, obviously, we're replacing that hormone, so we have to measure the levels, and we might need to treat the disease if there's a disease process going on. So those are the three things we're doing. We're monitoring, replacing hormones, and treating disease. So there are a few general principles that we use when managing patients. So I'll just run through those. I've just made this, made this up. This is PPP, pre-pregnancy plan. So the ideal scenario is patient comes along to me before they want to get pregnant and say, right, I'm planning pregnancy. What do I need to do with each one of the diseases or the processes we've got here? And then we can make a very clear plan, and then we know what's happening when they get pregnant. So that's the ideal scenario, okay? So during pregnancy, if we're concerned about a disease process, we would follow it up more closely. So we might see someone each trimester for certain issues. Then we may decide that we have to intervene on disease while the person is pregnant. So what we try and do is, if we can delay treatment while the person is pregnant and it doesn't put the mother at risk and doesn't put the baby at risk, then we would try and delay treatment and then think about treatment once the mother has given birth. But if we can't delay treatment, then we think about how can we safely deliver that treatment while the mother is pregnant. Okay? So those are the general principles. So what I want to do is just run through some of those diagnoses and just talk a little bit more specifically about what we might, or the issues we might get when we're dealing with each one of these conditions. So firstly, hyperparathyroidism. So one of the parathyroid glands, or more than one parathyroid gland, is overactive. So in these patients, the calcium levels are high, so that's the issue that we have to deal with. So why is a high calcium a problem during pregnancy? Well, when you've got a very high calcium, what tends to happen is you pass a lot of water. So you get very thirsty, you pass a lot of water. So you tend to dehydrate. So obviously that's a problem for mum if she's got a very high calcium. So people can manage a slightly high calcium and they manage that all right. But I'm talking about if the calcium really goes up, that can be a problem. So mum can get dehydrated. If your calcium is very high, it can affect your heart rhythm. Yeah? You can develop kidney stones if you've got a high calcium. So those are all the kind of things that the high calcium can cause in mum. In the baby tolerates a high calcium quite well, but the problem comes after birth. So once the baby is born, the baby actually gets the opposite problem, where the calcium, if they've been exposed to a very high calcium level during pregnancy, their calcium can be a bit low. It recovers, but it can be low initially. So those are some of the problems we get if we don't treat the condition. So we talked about the different scenarios you might have with each condition. So for instance, if someone has had hyperparathyroidism and they've already been treated, they may be on calcium, they may be on vitamin D. So our job is just to maintain those in the normal range. Remember, when baby's skeleton is developing, where's it getting all the calcium from? It's getting it from mum. So one of the things is you've got to make sure the vitamin D level is fine. So let's say that you've just found that someone who's got active disease, so they've got hyperparathyroidism, and the level of calcium is not so high. So what do? We ask people to maintain their hydration. So drink plenty of fluid. That will bring the calcium down and keep them safe. So that's the first thing they do. There are some medications that we sometimes give to patients. So in some MEN1 patients, they might be on this drug called cinacalcet, which is a medication which lowers calcium. So again, so this is the thing we mentioned about all drugs. This is a drug that you would stop if someone was pregnant, but if you look in the literature, people have given cinacalcet during pregnancy, and those pregnancies seem to be fine. So it's something that we would tend to stop because there's not enough data about it, but it has been occasionally given. Now, let's say someone had a very high calcium, one that we couldn't ignore and we couldn't manage. What do? Well, we do, in extreme scenarios, operate on patients. So we would operate, and there's a window of time where it's relatively safe to operate, and that's the second trimester of pregnancy. So if you operate in the first trimester or the last trimester, you can get problems in terms of miscarriage or induced labour, whereas the second trimester is relatively safe. So if somebody needs intervention and surgery and you're in trouble, you can try and do it in the second trimester if you need to. But again, we would only do that if the calcium levels are going very high. So, pituitary for patients with MEN1. So the typical pituitary tumours that patients get, prolactinomas or acromegaly, too much growth hormone, or they might get a non-functioning tumour. So a couple of things you need to remember. Again, we talked about physiology changing. If you look at the pituitary gland in a normal patient without MEN, the pituitary gland tends to get bigger during pregnancy, okay? And the other thing is the prolactin goes up during pregnancy. So imagine if you had a prolactinoma. There are a couple of different medications, some of you might be aware of these. So bromocriptine or carberglin, these are medications which lower prolactin. So if someone's got a large tumour in their pituitary and we're worried about it getting bigger, the danger is that the eye nerves run very close to the pituitary. So if the tumour gets bigger, the vision can be affected. So in some patients, we continue bromocriptine and carberglin to make sure the thing doesn't get bigger. Okay? And in those patients, we'd be following them up very closely. So each trimester, we would see them, and we'd be assessing their visual fields to make sure that it hasn't got any bigger. You can do a scan, but as I say, it's difficult to interpret in pregnancy. The last thing you've got to remember is certain drugs will have effect. So bromocriptine and carberglin they reduce your prolactin, but you need prolactin to breastfeed. So after the birth, breastfeeding may be an issue if the prolactin is being brought down too much. So that's one of the issues you need to be aware of, and that needs to be discussed early on. Okay, I thought this would be a good opportunity. So some patients who have had pituitary disease end up being on hydrocortisone. Yeah. So hydrocortisone, very important to be aware of the rules in pregnancy and in normal life, which will keep you safe. So we have steroid precautions for patients on hydrocortisone, so that's important to remember. You normally can stay on the dose of hydrocortisone you're on pre-pregnancy early on in the pregnancy. So you just keep going with the same dose of hydrocortisone. But towards the third trimester of pregnancy, the requirements go up. So you might need a little bit more hydrocortisone. And then the important thing is during labour, you will need more steroids. So in the second stage of labour, we normally recommend people have parenteral hydrocortisone, so an injection of hydrocortisone, and that might need to continue for 48 hours, and we need to be giving fluid and watching the sugar. So those are all the things that can be affected when someone's not got enough steroid in the system. So that's important to remember. Now, just to run through the other pituitary hormones, just in case someone's on replacement. So remember, if you're on thyroxine, requirements go up during pregnancy. So you often need 30 to 50% more thyroxine, so that's important to get right. Estrogen, progesterone, obviously you won't need during the pregnancy if you're on that. Desmopressin, so that stops you passing excess urine, and the requirements may go up later in pregnancy, so that's something we need to monitor. And then growth hormone we normally stop during pregnancy, though again it has been given in some cases and it seems to be all right, but again not enough data, so we would tend to stop that. So pancreatic neuroendocrine tumours for patients with MEN1. So the common ones are gastrinoma, where you produce too much gastrin and you have lots of acid in the stomach. And then insulinoma, too much insulin. So you've got lots of insulin and your sugar levels drop. Those are the commonest tumours. So how do we treat gastrinomas? So usually, or now, we're tending to treat it with medication. So the common ones you might have heard are proton pump inhibitors, something called omeprazole is a common one. So people are often on high doses of those. And there's a fair amount of data of patients who are pregnant on omeprazole, and it seems to be fine. Insulinoma, the main issue is just sugars dropping. So in pregnancy, we would try and keep the sugars up, and there are various ways to do that. So if someone has active disease, so it does happen, some people have got pancreatic neuroendocrine tumours and they get pregnant, this is where you definitely need a pre-pregnancy plan if you can have one, because you need to be aware of medications you might be stopping and what the disease is doing. What we like to do in endocrinology is get a feeling for the tempo of disease, how quickly is disease moving, and that will give us some steer on making a prediction about if we're not treating a disease, what's going to happen during pregnancy. So it's really important to be monitoring these things closely. And again, we're trying to manage symptoms and delay intervention for as long as possible. Some MEM patients have had a lot of their pancreas removed or part of their pancreas removed, and they've developed diabetes. So again, in pregnancy, if you've got diabetes, we know that diabetes, which isn't controlled well, can cause complications. So you need to get control of the diabetes pre-pregnancy if you've developed diabetes, and then you need to be attending an antenatal diabetes clinic for close follow-up, and they'll be obviously monitoring fetal growth during that time. So diabetes in pregnancy, there's usually a good setup in most hospitals to manage that. So MEN2, patients get medullary thyroid carcinoma. So the majority of these patients would have had that disease treated early on in life. So most of them would have had a total thyroidectomy, all the thyroids removed. So we'll usually be just monitoring their thyroid hormone replacement and their vitamin D and calcium levels. But again, if they've got residual disease, this is, again, you must have a planned pre-pregnancy ideally. And it's a matter of seeing, again, what the disease is doing, how quickly it's moving. It may be moving very slowly and pregnancy is not going to affect it. So those are the decisions that need to be made. And the final one is the adrenals in MEN2. So patients get pheochromocytomas. So I've got a nice picture for you there. I don't know if you can spot. So that's an MRI scan. Can you spot there are two things to spot there. I don't know if you can. Any guess? Very good. So there's a baby there. Can you see that? Anything else? Looks a bit funny. Yeah. So this thing here, the golf ball, as someone said, it's actually that bit and this here. So that is a pheochromocytoma. So, is this something I want to manage during pregnancy? No, not really. So we would like to avoid that if we can, but it happens. If it happens, we can manage it. So the key thing is identifying these things. So if you can identify it before, that's 100% safer. If you can't, we can still manage it, but that's the issue. So, pheochromocytoma, these are tumours of the adrenal which produce adrenaline, noradrenaline, can put your blood pressure up, make your heart race, and you can become quite sick. So we'd like to avoid that if possible. If not, we can treat it. So the key thing is making patients safe, so bringing the blood pressure down. So there are medications which we can give which are safe in pregnancy. And then again, there's a key decision about surgery. So this kind of thing, remember, baby in the tummy, anything that presses on this tumour, it will start to release adrenaline, noradrenaline, so that's dangerous. You can imagine if someone goes into labour, that's very dangerous. So we need to avoid labour. You would have to have a C-section in the scenario of that picture there. And the question about tumour, so people have done joint procedures where baby comes out and they take the tumour out at the same time, or they actually just block the patient, get baby out, and then sometime later when everything's settled, they take the tumour out. So there's a number of different ways you can do that. And then again, a lot of patients come to us who have had both tumours in both adrenals. They've had both adrenals out. They'll be on hydrocortisone and fludrocortisone. So again, we need to use steroid precautions for those patients. So MEN1 in pregnancy, definitely manageable. If you have to see your endocrinologist, make plans, and just monitor things closely. So I thought I'd end with that. Good. Okay, fine.